Welcome students. We will be now uploading some new videos in clinical snippets. Specifically, we will discussing these small videos as scenarios. So we will be dealing with some scenario snippets. So today, what scenario we are going to discuss is about the pupils. Very important and very interesting. We will be discussing scenarios that a patient is in coma and after examination of pupils, what conclusions we will get as far as lesion is concerned. That is very important in emergency medicine. So a brief account on the pupils first. We will not dealing with the neuroanatomy and anything, just clinical examination and lesions. So the normal pupil is usually 2 to 4 millimeter in diameter. And if you throw a bright light into the pupil, then the pupil constricts. And in dark, maximum in a normal person, the pupil can dilate up to 4 to 8 millimeter. And brightest of light में 2 to 4 millimeter तक constrict कर सकता है. So basically the range is from 2 to 8 millimeter is a normal pupil. Now normally when we write the pupillary findings, it is like this, written like this. The pupils are equal in size, round, reacting to light, that is constriction, and accommodation. If for example in normal person you will ask the patient to look far and suddenly look to a closer thing like a pen or a finger, the both pupils will adduct and the both eyeballs will adduct and the pupil will constrict. That is the accommodation reaction. So again, just finally repeating, pupils are equal in size, that is around between 2 to 8 millimeter. More bright light छोड़ा है तो 2 to 4 millimeter. Reacting to light and accommodation, round in size. So now our scenario is coma. The patient is in coma, and what is the first scenario? In a comatose patient, if we are getting a bilateral pinpoint pupil, it is just pinpoint pupil, and reacting to light. So what are the conditions? The first will be we will have to rule out pontine bleed, pontine hemorrhage. Pontine hemorrhage should be ruled out. What are the classical findings you will get in this comatose patient? With pinpoint pupil, obviously the patient is in coma, and when you go for a neurological examination, you will find spastic tetraparesis, spastic quadriplegia or tetraplegia. That means all the DTR are exaggerated, plantars are up, Babinski sign positive, coma, pinpoint pupil, sometimes altered breathing, and patient dies. So this is how the clinical examination, and it is pontine bleed. Now a second scenario, patient is nearly comatose and pinpoint pupils slightly reacting to light. Okay, there is slight reaction, but still it is pinpoint, and patient is in coma. Deep tendon reflexes are absent, or there is hyporeflexia. Plantars flexor or mute. So here you will diagnose opioid overdose. Or opioid poisoning. So two scenarios of pinpoint pupil. So coming to scenario number 2, in a comatose patient, in neurological examination, when we examined the pupil, we saw that one of the pupils is dilated and fixed, not reacting to light, and the other pupil is normal in size, reacting to light, and one pupil is dilated, fixed, not reacting to light in a comatose patient. So this is a very dangerous scenario. It is a catastrophic scenario. What we will think is uncal transtentorial herniation. If you see, this is the cerebrum, this is the posterior fossa, and the cerebrum is separated from the posterior fossa by the dura mater infolding, that is the tentorium cerebelli. This is the falx cerebri, the dura covering the cerebrum, falx cerebri, and this is the tentorium cerebelli, which separates the supratentorial from the infratentorial part. The infratentorium of the brain contains the brainstem, midbrain, pons, medulla, and that is a very vital area. Less space, and most important structures of the brain are clustered in that small area. What is happening here is, if there is a lesion here, say for example a hematoma or a tumor or whatever, road traffic accident hematoma which is expanding, or any tumor which is expanding in size, what is causing? It is causing pressure from above. This above pressure is gradually leading to herniation of the temporal lobe. Which part of the temporal lobe? The uncus of the temporal lobe. This is the temporal lobe. This is the uncus of the temporal lobe. The uncus of the temporal lobe is herniating through the tentorium cerebelli into the posterior, into the infratentorial fossa. And here the brainstem starts, midbrain, pons, medulla, and in the midbrain the third nerve nucleus is present laterally here. And when this uncal part of the temporal lobe is herniating, it is compressing the third nerve ipsilaterally, and in that eye, because of third nerve compression, there is a dilated, fixed, non-reactive pupil. Medical catastrophe. Immediate neurosurgery opinion should be taken. Immediate you should start anti-edema drugs, neurological anti-edema drugs like dexamethasone, mannitol should be started. 3% normal saline, 3% hypertonic saline should be given, and immediate neurosurgical consultation should be taken for possible surgeries to decompress the brain. And second, if now gradually in this patient, after this, the other opposite eye where it was initially normal, it becomes dilated, because if untreated, pressure continues and this part again compresses this, and there can be a situation which is known as the central transtentorial herniation. Excessive intracranial pressure may now push both the temporal lobes, and all these structures will come downward. These supratentorial structures will come and push onto the brainstem and cause bilateral fixed non-reactive pupil. It is as close to the final stage, and again still, if possible, neuroimaging should be done so that some intervention can be given. So in a comatose patient, if we start, when we examine the pupils are totally normal. That is, pupils are equal, round, reacting to light and accommodation, and the patient is in coma. So what are the possibilities that are to be thought about? Then it is a metabolic coma, so all the metabolic parameters, septic encephalopathy, diabetic ketoacidosis or hypoglycemia, and drugs. So basically there is no possibility of an intracranial lesion which is causing the coma. We have to rule out non-intracranial causes, systemic causes, that is the metabolic and drug-induced causes. Last scenario, the patient may not be in frank coma, but there is some problem in the cognition, drowsiness, stuporous or ecstatic abnormal behavior, as if the patient is in encephalopathy, whatever, and the pupils are examined, and if bilateral pupil are miotic pupil, not pinpoint meiosis, not pinpoint. What are the conditions we will think? Again, alcohol induced coma or stupor, organophosphorus poisoning because of cholinergic poisoning, organophosphorus poisoning, barbiturate poisoning, and phenothiazine toxicity. And if the pupils are bilaterally mydriatic pupil, bilateral dilated pupil reacting to light, then atropine, scopolamine, amphetamines, LSDs, cocaine, marijuana, and ecstasy, all these drugs will cause bilateral dilatation of the pupil.
अरे हेड इंजरी का पेशेंट आया है, जल्दी से इनके वाइटल्स लो और ऑप्थेल्मोलॉजिस्ट को कॉल करो फंडस एग्जामिनेशन करने के लिए। पैपिलोएडेमा रूल आउट करना पड़ेगा।
रुको रुको रुको, क्या कर रहे हो?
अरे हेड इंजरी का केस है, मिड्रियाटिक सोल्यूशन डाल के प्यूपिल डाइलेट कर रही हूँ, फंडस एग्जामिन करेंगे, पैपिलोएडिमा हो सकता है।
नहीं, एक्यूट हेड इंजरी के केस में पैपिलोएडिमा डेवलप होने में टाइम लग सकता है। अगर आप मिड्रियाटिक सॉल्यूशन डाल के एक आंख डायलेट कर रहे हो तो ब्रेन इंजरी की वजह से जो ब्रेन हर्निएशन होता है उसकी वजह से जो प्यूपिलरी चेंजेस है वो मिस हो सकते हैं। सो आप डायलेट पैपिलोएडिमा देखने के बजाय उसको इमेजिंग में शिफ्ट करके फर्स्ट यू विल रूल आउट।